I'm Dr. Neha Pathak, and welcome to our four-part interview with Dr. Daniel Clauw about the state of the art in the management of patients with chronic pain in a post opioid world. Dr. Clauw is a professor at the University of Michigan in Ann Arbor, where he's running the largest clinical trial to date in people with chronic back pain. Our series will look at best practices for pain management referrals, how opioids fit into the treatment armamentarium, ways to optimize patient communication and expectation management when it comes to pain control, and approaches to multidisciplinary care. Today, we're talking to Dr. Daniel Clauw about ways to optimize patient communication and expectation management when it comes to pain control.
Thank you so much, Dr. Claw, for taking the time to be our resident pain consultant today. So, I would love to move our discussion to communication. Because a lot of patients, especially if they've been on opioids for a long period of time, that's a very difficult discussion to have. And when we're thinking about pain and pain management, it's an uncomfortable zone in modern medicine because we don't necessarily have objective criteria. We're really sort of gauging benefit and we're gauging harm based on subjective information from pain scores to activity levels to enjoyment in life. So, how do we have this conversation? How do we ground our communication to begin with? So, the expectation of what success looks like in treating the pain in the office is equal on both the patient side and the provider side.
I think that the individuals that are already on chronic opioid therapy do need sort of a special paradigm because the first thing I would say emphatically is you can't pull opioids away from people. You have to convince them that that continuing to take an opioid may not be in their best interest. And that's a big difference between cognitively about sort of how you approach this as a provider. And I try to teach people that you should look at this as a process where maybe in one visit you say, are you aware, Mrs. Jones, that the recent studies that have come out suggest that if someone with chronic pain is taking an opioid, the risk of them dying in the next year is almost double if they weren't on that drug, that single drug. And then in the next visit, say, are you aware, Mrs. Jones, that in studies that have looked at people like yourself that are on chronic opioid therapy who have tapered, that usually at least half of them, if they taper, will either note no worsening of their pain or an improvement of their pain. And do you know whether you're one of those half or that you really actually need the opioid? Um, and I think that if primary care physicians that are prescribing those opioids are really supportive and say, if you start a slow gradual taper and you really get worse, I'm good with you staying on that opioid. But what I'm really worried about is that you're one of these 50, 60% of patients on chronic opioid therapy that if you stopped it, your pain would be no worse or even better. And you're subjecting yourself to this huge increase in all cause mortality um, in spite of the fact that the drug is harming you. And so, but again, if you go into a visit and you say, I'm going to get this person off of opioids, that will never work in my estimation. You have to, a joke I use is you have to play chess rather than checkers. And you really have to just plant different seeds over time in this individual and try to gradually get them based on the science, the data that you give them to say, maybe I will try a slow gradual taper as long as you're going to be there to back me up. If I get worse as I taper, then I'll try this because I don't like being on this drugs. I don't like being looked at as an addict every time I go into the pharmacy. There's a tremendous amount of stigma associated with being on chronic opioid therapy. Most of them don't like that. And that's another thing you can insert is that I'll bet you don't like, having to come every month for your prescription and beg for your, drugs if you run out early or whatever. But all of those things are just ways that you can gradually coax the patient into themselves thinking, maybe I should try a slow gradual taper, because, I don't really like being on these drugs.
Yeah, I think that is such an important point. And what I hear often from patients is that conversely, that they're also very frustrated by the encounters because they feel like they're not being trusted or that they have to perform in a certain way to show that they have a certain level of pain in order to have their pain be acknowledged. And if they are on opiates there or opioids, there's a very real sort of concern that they have that there's already this mistrust in the relationship with their provider, that their provider is sort of has this end game to eliminate it. But I think that it's so important to think about it in the way that you are discussing, which is this is a long-term goal and not necessarily something that you can achieve over the course of 1 or 2 or 3 visits.
Exactly.